So we are taking the pretest for vascularized composite allograft transplant immunology. So we'll be taking the questions randomly. So anybody that wants to take a question can just signify and start with the question. Is anybody taking number one? Okay, let me start. Which transplant type best describes the transfer of tissues between unrelated members of the same species? A. Autograft. B. Xenograft. C. Allograft. D. Isograft. E. Vascularized graft. I choose allograft. So who is taking number two?
Which one of the following is correct regarding major histocompatibility complex antigen? There are three classes of MHC molecules. MHC molecules provide an immunologic fingerprint. Class 1 molecules display peptides from outside the cell. That's wrong. Class 2 molecules are present on unreplicated cells. That's wrong. So this is for 1. HLA-DP, DQ, DR, DQ are all class 1 molecules. 4, they are class 2 molecules. So I choose B. They are the immunologic, it provides an immunologic fingerprint.
Okay, so someone should take number 3 now.
Which one of the following is correct regarding the acquired immune system? A plays a minor role in rejection of transplanted tissue. B, the sole primary mediators are the B lymphocytes. C, the acquired immune system is not capable of memory. D, it displays an enhanced secondary response. E, activation of T cells require a single stimulus. I'll go with B. The sole primary mediators are the B lymphocytes. I hope I'm correct.
Okay, so who is taking number 4?
So which one of the following is correct regarding allograft rejection? A. Acute rejection occurs within the first few hours and is mediated by donor-specific antibodies. That is wrong because it's first few hours. B. The direct pathway of donor organ recognition predominates in chronic rejection. C. Chronic rejection occurs over weeks to months. That one is false. D. Acute rejection is difficult to treat, and at present, no reliable treatment. I think is the one that has treatment among the others. E. Accelerated rejection involves a secondary immune response that is mediated by sensitized T cells. I think I will choose E.
Okay,
Yes,
so let's go to number 5.
You are part of the team preparing a patient for a full face transplant. Tissue components to be included are skin, muscle, nerve, vessels, mucosa, and bone. An immunosuppressive regimen needs to be selected. Which one of the following is the most antigenic tissue? Fat, muscle, nerve, bone, skin. And the answer is skin. I choose skin. E.
Okay, let's move on. A patient presents with
Okay.
diffuse erythema of the skin after facial transplantation and frank epidermal necrolysis is confirmed histologically. Which of the following grades best describes the problem according to the Banff criteria? 0, 1, 2, 3, or 4? Well, I think 0 has no features at all, or the features are quite rare. 1, it's when you have there are features within the vessel but not manifesting yet. 2, you begin to see features a bit on the skin but not frank necrosis. 3, you'll find erythema on the skin. 4 is when you have frank necrosis. So the story they gave said that there was epidermal necrosis on the skin, so which means that it's grade 4. So I choose E.
from the list, select the immunosuppressive agent that is most likely described in each of the following statements. Each answer may be used once, more than once, or not at all. A. This agent works through inhibition of calcineurin, leading to inhibition of gene expression and T cell activation. It has similar side effects to cyclosporine, but displays increased neurotoxicity. Okay, okay. So I will match each one to each of the A, B, and C, right?
Yeah, you just choose from A to G, which you feel is the right answer.
Okay, so the other one that acts through calcineurin inhibition.
Okay, so let's start the discussion now. So we'll start with introduction, which will have statement of surgical importance and probably definition of terms. Then we'll go to brief history or relevant history, and then the immunologic basis for transplantation, then classification of the immunosuppressive agents, then the organ donation criteria, where we'll also talk about the ideal organ donor, and then the types of organ donation, then organ retrieval and preservation. After that will be the application of transplantation in plastic surgery. Here we'll list out the different ones that are relevant to plastic surgery. Then we'll go to the complications of um, organ transplant. That will be further classified maybe into anesthetic, the surgical complications, the immunosuppressive complications, then rejection. Of course, the rejection will further classify them into the different types of rejection. Then the ethics of donation, and then we'll talk a little about brain death, the definition of brain death, then the local regional issues, the recent trends, and then we'll conclude. So I'm done. I don't know if there are any comments, corrections, new outline. I'm open to suggestion. Thank you.
Well, I've heard your outline. Well, I have some issues with the outline though. Personal, my own view. I'm just wondering what would be the relevance of brain death to transplantation in plastic surgery? I'm just curious. I
Uh,
don't know. And if, because the whole idea is for us to have time. I agree with the other parts of what you said. You understand? I'm just wondering
Okay.
because ideally you should be able to spend more time in the, the question was transplantation in plastic surgery. So you want to have more time in dwelling on the applications really. Every other thing you want to mention, yes, but when you now get to the application, you want to spend a bit more time. So I'm just wondering what the relevance of brain death would be in plastic surgery. I don't know. It's just my own opinion. That's the only query I have about your outline. The outline is beautiful. We could dwell on it, but the brain death issue, I don't know. Others can share their own opinion. We're all here. So we know what to write if this type of question pops up. Thank you.
Okay. Thank you.
Yeah, thank you very much. I think I agree with him too because when one broadens the topic, the discussion like that, there are actually very many things that one will have to discuss, which will not may not be exactly relevant. For instance, now you can be talking about, okay, if you are talking about that, how about things like maybe heart beating and non-heart beating donors and other stuff like that that are general stuff. You understand? So there are actually very many things, a whole gamut of things that are up for discussion if one is going to involve all of them. So I think I tend to agree. We should keep to what is relevant to plastic surgery, just as stipulated in the question. So anyway, one may write maybe one or two lines briefly on those other things, but we dwell more on the things that are relevant to the question. Thank you.
Okay. Thank you for that. More comments, corrections.
I think we can proceed.
Okay. Can somebody introduce the topic?
Okay, let me introduce since nobody's saying anything. Well, by way of introduction, transplantation is a transfer of an organ or tissue from one site to another within the same individual or from one individual to another. By this definition, it means that the procedures, one of the common procedures in plastic surgery, which involves grafting and raising of flaps in plastic surgery, all falls under the ambit of transplantation. Transplantation, however, over the years have been quite used as a word to refer to the time of the transfer of an organ from donor to recipient. So which means that this transfer could either be autotopic, that's when the organ is actually put in a place in its native position, or heterotopic, when it is placed in an alien location, like a location which is not its typical anatomic position. First transplant was carried out in the 50s, 1950s, and it was done by Joseph Murray. And this transplant was a kidney transplant between two siblings. It was what set the stage for transplant surgeries in general. Plastic surgeons battles with the problem of actually having to replace lost tissue with tissues of similar structure. So there is no better way to have achieved this through the use of transplants. That's what I was rating in my introduction. Thank you.
Okay, thank you for that. Are there any comments, additions, corrections?
And I want to add, thank you for
Go
that.
ahead, please.
I want to, yes, I just want to add that formerly it was just single organ transplant that could be done. But due to improvement in techniques and even immunosuppressive therapy, we would have things like vascularized composite allograft possible now because of all this improvement. However, the future now, long-term success of this procedure, it will become routine when we're able to achieve an immunologic tolerance, and when we're able to achieve this, when there'll be success in the science trying to achieve low dose immunosuppression and for shorter therapy. One of the breakthrough aspects in plastic surgery that has tried to improve that has tried to improve options available for patients that have devastating injuries or damage to their parts where repair is not feasible. So it's one of the great strides currently in plastic surgery. Thank you.
Thank you, Dr. Anna.
Okay, thank you for that. Please, any more additions, corrections? Okay, so I wanted to also add, um, I think at this point, to narrow it down a bit, you mentioned the fact that autographs are also part of this, but for the purpose of this discussion, you're going to be describing mainly all the others outside the autograph, because I mean there isn't much to talk about that. I don't know if it's important or you still go to town since autograph basically you just be talking about flap and skin grafts.
Well, by just introducing, so we don't write so much on introduction. We
Okay,
want to
okay.
keep it straight and simple. So we have time to elaborate on other parts where we'll get more marks. Like introduction is 0.5 marks, so make we not spend more time.
Okay. Can we move to the history?
Okay, let me volunteer for the history so I can get um, transplant history is as old as time. However, people have tried different things with varying levels of success. But worthy of note, the first successful kidney transplant by Joseph Murray and his colleagues. It was done between identical twins, and probably that's why it was successful. Skin transplants, um, where one could find the earliest documentation of this um, skin grafts was in 1912 and 1914 by Scone and then Lexa, respectively. However, these grafts didn't survive beyond 3 weeks after a transplantation. Um, Talking about discovery of immunosuppressive drugs for transplants, it can be credited to people like Charles Zukowski and Warren Kahn, and they're the ones that introduced um, 6-mercaptopurine and then azathioprine, which has helped in immunosuppression. Then also things like the human leukocyte antigen, which was discovered in 1958, that went beyond just blood typing and into tissue typing to be able to avoid graft versus host disease. Um, that's a summary of relevant history. If any that anyone wants to.
Okay, thank you for that, Jeff. Um, okay. I think there's still some, well, there's a lot about the history, Sha, so of course, time is important. I don't know, maybe for MCQ reasons, it's also important to note that Sushruta was the one that pioneered rhinoplasty and started with ears and lips. And Gaspari, I think it's Taglia something, also did some work on rhinoplasty.
Tagliacozzi,
Yes,
exactly.
Taglia. Then Baronio. I think, okay, you mentioned Baronio and skin transplants. Um, then there was something about accelerated rejection of allogenic tissue from when they were testing it on pilots. I think Dr. Gibson during the World War II, it was one that described accelerated rejection of allogenic tissue in pilots that have had presence of humoral antibodies from prior exposure. And one of the most notable people in the history for immunology, especially, is Medawa. Or is it Medawa? I don't know the pronunciation. It was the one, him, then after him, Bellingham and Brent laid down the foundation for immunology. Then I think the first hand transplant was in 1999. I
No,
mean,
no.
no, sorry, 1998. 1998. First
Yeah,
unilateral hand transplant.
Yeah,
Ah.
the
no.
first, the first
The first
modern.
was in
Sorry,
1963 and it failed.
No, that's why I say it's the first successful. Okay, sorry, I want to say successful. The first
Uh-huh.
successful was in
First successful. You
1998.
just said the first hand.
Sorry, I apologize.
The
So the
first
first one was in
one was in
1998. I
1963
think it
and
was
it
a
failed.
Frenchman.
It was
Uh,
successful for the first time in 1998 and in France.
yes.
Yeah, because the
Then
next one was not done in the US and China in
yes.
1969. Yeah.
Mm. Then face transplant was 2005.
But you need to put an adjective. It was partial.
So okay, it was partial. Okay.
Yes, it was partial. The first face transplant was partial. It was in 2005. Then it was now repeated in 2010. That was now a full face transplant. But an extensive one involving the scalp was now done in 2012 in the US.
Okay. 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 Any other additions? Can we move past the history?
Please let's move past the history. We are done with history now.
Okay, so the next one is immunologic basis for transplantation. Is anybody going to take that one?
Okay, let me take it and then we'll add to it. So the immunologic basis, whenever following transplant, whenever a foreign tissue is introduced into the body, there's an immune response, allogenic immune response that occurs. And the what is responsible for that is what we call the major histocompatibility complex. This major histocompatibility complex is the immunologic blueprint of an individual, is what differentiates individuals. So in humans, this major histocompatibility complex is also known as the human leukocyte antigen, HLA. You get, so they are, so these major histocompatibility complex, they are located in the short arm of chromosome 6. And then what they do, their main aim is to bind peptides that are processed by proteins within the cell. So they interact with, as we'll see, depending on the so we'll see how they do. So remember, there are two types of immunity. We have the innate immune response, and then the humoral or adaptive immune response. So the components of the adaptive immune response, mainly the T lymphocytes, are what are responsible that what is responsible for the action that we see in this following transplant that will eventually lead to transplant rejection. So the major histocompatibility complex that we mentioned, there are two types. We have the MHC1 that is expressed on nucleated cells like platelets and other nucleated cells, maybe things processed where viruses are also involved. And there are three genes. There are three types there. We have in those in the MHC class 1, we have HLA-A, B, and then C. And then the MHC class 2, we have the HLA-DP, DQ, and then DR. So these ones, so we have this MHC. Then the T cells that are going to be recognized, because what happens eventually, how the body is able to, so this HLA, I've mentioned that there are two types of HLA. Now, T cells that are going to be recognized by the body, there are two ways in which the T cells can be activated so that eventually they'll be able to recognize, because we say that the T cells are the adaptive immune response. So there are two ways that they can be activated in order to pick up the foreign antigens that has been brought into the body. There's either the direct pathway or the indirect pathway. The direct pathway is that the direct pathway is that the antigen presenting cell of the individual, that's the donor antigen presenting cell, is the one that will now go to the lymphoid organs and then show themselves to the T cells there, stimulate the T cells there. So that direct pathway is what is mostly seen in the acute rejection. While the indirect pathway is that the antigen presenting cell of the individual, the recipient, will have time to take up those peptides, process it, and now go and present it to the T cells. The T cells will interact with it via the T cell receptors. However, what happens? How are the T cells eventually activated so that they will now be able to effect this rejection? So there are three signals that have to occur for rejection to take place. The first one is the foreign antigen recognition that we've already mentioned. The foreign antigen recognition, either via the direct or the indirect pathway. On the surface of the antigen presenting cells is where we have the major histocompatibility complex that would have a place to bind the peptide of that's the peptide of the donor. We've mentioned that it's either direct or indirect pathway. So this first one, this foreign antigen recognition, is that following the activation, they'll go to the secondary lymphoid organs, and then the cells there, the effector cells that will try to affect this. Either we have the dendritic cells that are involved, dendritic cells, then we have natural killer cells. Those are some of the cells. Then we have the T4, and then what's the name? The T. Either we have the CD4 or CD8. So let's say, for instance, the dendritic cells as the antigen presenting cells, when they go in, attached to with the MHC on their surface, with the peptide attached to it, they go to the secondary lymphoid organs, and then there they activate the T cells. The T cells will now bind to this peptide on the MHC complex via their T cell receptors. So this complex, the complex in which we have the antigen presenting cell interacting with the MHC of the MHC on the APC of either whether the donor or the recipient, if it's direct or indirect. Plus, we have some other cells that try to improve this response. That, like, there are some signal transition molecules that are there that will help to improve the binding of this, is what we call signal 1. So this is one of the first signal that is needed for the T cells to be activated. So this signal 1, that's that complex between, they call it self MHC antigen complex. I've forgotten the name for that. So that's the first thing that needs to happen. But after this foreign antigen recognition, there are two more things. The second signal that needs to occur is what we call the co-stimulatory signal. This co-stimulatory signal is that in addition to this this recognition of the foreign antigen, the antigen presenting cell will also help to further activate the T cells so that it will be able to effect its function very well. Remember that the T cells, we have two types of T cell. We have either the CD4 or what's the name? The cytotoxic T cells or the T helper cells. You understand that on either the CD8 or CD4 respectively. So the second one, this co-stimulatory is what will help, the co-stimulation will help to further activate the T cells. And then finally, we have the third thing that have to happen, the activation, the full activation of the cytokine. The full activation of the cytokine. There are some this co-stimulatory, there are some cofactors there. There are some things I'm forgetting now that also help to mediate this response. Then finally is the one that's okay. Yes, we have B7/CD28 signal pathway that help to improve the response. Then finally, after the cell has gotten this signal one, that's first signal one, and signal two, it will now activate it will now activate signal transition pathways. This signal transition pathway, after the T cell have received signal one and signal two, will help to activate signal transition pathway. These pathways are what we call, there are three main pathways that are activated. We have the calcium-calcineurin pathway, and then we have the NFKB pathway, and then there's also RAS mitogen activated protein kinase pathway. So once all these pathways are activated, they will further release they will further release transcription factors like NFKB and then AP1. This would lead eventually to genes that will encode cytokine release. For instance, interleukin-2, CD154. And these cytokines, especially interleukin-2, is what will help to initiate the proliferation and expansion of the T cells. Sometimes when this proliferation and expansion, the final thing has occurred, is called signal 3. This will now make the cells to now carry out their effect. For instance, the cytotoxic C cells the cytotoxic T cells will help to mop up any foreign antigen that is there, while the T helper cells, apart from the fact that it will help more T cells to be produced, it will also help the other things like the macrophages, the monocytes to be able to carry out the action. So this, when the T cell is fully activated, to go and affect the whatever the host, sorry, I beg your pardon, it will go and affect the organ or tissue that has been transplanted, and it will now eventually affect the rejection response that we'll see clinically. So this, in summary, what happens following transplantation. Thank you.
Okay, thank
Okay.
you very much for that. Please, are there comments, questions, additions? Sorry.
Okay. Thank you, Chief Honor. Well, let's simplify a bit, just so that we'll have some take home when we actually can write this in the exam. Now, I like the way she started, the fact that the whole process of transplantation is you want to be able to curb rejection. You want the transplanted tissue to stay and that you have harvested from the donor to stay in the recipient. That's the whole idea, which means that first of all, you need to talk about the antigens. The antigens are not just the major, like you mentioned, the major histocompatibility complex. There are other antigens. So first of all, you start by saying, where are the antigens that actually facilitate rejection? Those antigens are seen in the major histocompatibility complex that you mentioned. They are also on the ABO blood grouping. We also have some minor. So once you address that part of talking about the antigen, you go to, because the major is major and that's one that it's more of concern, you will not neglect the others. So that's first. So when you now went to divide into group and started talking about the type 1, type 2, yes, it was straightforward. Things that were important you mentioned. You said the short term of chromosome 6, and the fact that it's not as if there are only 6 human leukocyte antigens. Those are the ones that are important, really, and they were divided broadly into 2. 3 were for the HLA type and the class 1, while 3 were for class 2. But in summary, they still said only 3 were important for rejection. That's because of MCQ. I'm mentioning this because you see some in MCQ, they'll now start listing some of the things. The only three that are actually important for rejection, I call it Dr. AB, is the from the class 2, it's just the D arrow, while from the class 1 is the A and B. So the others are not really important for rejection. MCQ. I've seen it several times in MCQ. Now, the other part that you needed to mention, which you also highlighted, was the pathway. It is either direct or indirect, and that you clearly explained. You told us what happens in direct. Direct was, in simplified form, is that you have a transplanted tissue, but that transplanted tissue within it has antigen presenting cells, which the recipient recognizes and now give an immune response. As against the indirect, where no, nothing is really seen. Polypeptides are present within the transplanted tissue, but they are not recognized by the T cells of the recipient until it has engulfed, processed it, and now realized that, okay, this thing is foreign. Then it will now present it to the antigen presenting cells of the recipient. That is the indirect pathway. But outside that, because of MCQ now, there are cytokines that are responsible for the direct, and there are cytokines that are responsible for the indirect. In short, for the direct, you have interleukin 12, while for the indirect, interleukin 4. Now, there are other cytokines that are now produced by the antigen presenting cells from the direct for them to have function. That is the interleukin 1 and interleukin 2, interferon gamma, and tumor necrosis factor alpha and beta. But all these interleukins that we are mentioning, the one that is of paramount importance is interleukin 2, which you must mention because that is the pathway for which the inhibitors of the calcineurin inhibitors, that is what they actually affect because that is the interleukin that actually make the helper T cells function. So, then, thirdly, in your discussion, so that we don't go too far, is that I first of all talked about the antigens itself. I talked about the rest and the antigens that are responsible. Then we talked about the pathway. Remember when we were talking about the pathway, we talked about the fact that immune response will be generated. What is the effect of those immune response is what we should now discuss. Now, the effect is that from the direct on its own, there will be activation of macrophages and natural killer cells, which will kill cells via direct cell lysis (MCQ). But there will also be activation of cytotoxic CD8 cells that will have their effect via apoptosis or via production of lytic enzymes. That's on the direct pathway. But on the indirect, you have the production of what's it called now? The production of I'm not sure again. Um, if I remember, I'll say there will not be activation of even the other cells that you are talking about to carry out those cell to carry out the effect of the immune response. So if you actually read this whole gamut, just shorten it and summarize because the way you have said it now, I doubt we'll be able to write it in exam because that part may just probably take like 2 3 marks. You now sit down and write the long history that you said and forget what is necessary. This is in 1 hour. Thank you.
Okay. Thank you, Chief. Thank you for that. Any other corrections, comments?
Yeah, I want to add something here. Um, okay, what you are trying to say, Dr. Sazi, thank you. What you are trying to say in the last part is that in addition to those cell-mediated responses, this same process results in activation of B lymphocytes that now form plasma cells that now begin to produce antibodies.
Yes, thank you very much.
That results in some parts of the rejection. Okay, but I'm finding it hard to differentiate these two exactly as part of the direct or as clear distinction between the direct and indirect pathway. I think in both pathways, both the direct and indirect pathways,
the focal point is that in both sets of pathways, in both pathways, helper T cell is activated. So when
True.
it's
Very correct.
activated, depending on the environment, the cytokine environment, the environment of the milieu, the cytokine milieu in which the activation occurred. If it is where you have a lot of interleukin 12, it will differentiate into the that activated T cell differentiate into the cell mediated pathway where it now begins to produce, the killer activates the killer cells and then the cytotoxic T cells. While if the milieu is interleukin 4 mostly, it will now differentiate into the humoral
The neural
pathway
pathway
activation. You get so it is not really a distinction between the direct
between
activation
direct
and
or
indirect.
indirect. Okay, fine.
In both cases, it can differentiate into both cellular. In fact, it differentiates actually into both. But whichever predominates depends on which interleukin is predominant in the environment at that time.
Okay. Noted, sir. Very noted.
Okay,
Oh,
thank you.
okay.
I want to add
So,
some.
Sorry, I
I
wanted
want
to
to.
add something there.
Okay.
When I was reading from Grabber and Smith, the main difference that I saw there was that for the primary, sorry, is it primary? No, the direct pathway, the donor APCs go directly to, as in they activate the T cells directly. The donor APCs go towards the host lymphoid organs and tissues and direct the T cells and all the effector and all of that starts directly. While for the indirect is the recipient or the host APCs that take these cells, do the processing and present the donor antigens to the T cells before that whole gamut starts. That was the difference me I saw.
yes, yes,
Yes. So,
that's how it is.
Dr. Allison, I agree with. So, I looked through different texts. Now, these T helper cells. Remember that the T helper cells are CD4 cells, and the T cell population we have CD4 and CD8. The CD4 are mainly the T helper cells because if you check different materials, they try to explain it differently. I'm trying to go back, take us back to this last point about the T helper 1 that we're talking about interleukin 2, and then T helper 2 interleukin 4. Because if you check some materials like essentials, they'll tell you directly about the CD8 cells that they will be. Because if you say you're activating the T cell population, so you have CD8 directly activated, and then when you have CD4 activated, the T helper cells, depending on whether it's going to T helper 1 or T helper 2. If you look at that T helper 2 response, you still also have, in the T helper 1 response, you still also have some form of CD8 activation there. So Dr. Uzoho and I think this, what people are explaining is mainly in keynotes. You understand? So I don't know. Did you say anything like that? I just wanted to bring us back to that.
Did
I
you,
saw these
did
two
you read Converse?
variations. What did you say? No, no. But what
Converse.
you said is just as it was in keynotes. No, I didn't check Converse. It's just as it was. But the grab and smith, they take it through the signal. They'll tell you signal 1, signal 2, signal 3 when you are looking through grab and smith. If you go through keynotes, it tells you about this T helper 1, T helper 2. If you follow the T helper 1, T helper 2, you are just on CD4 cells alone. Do you get? So I don't know if anybody, I just need it to be clear. I don't know if anybody saw anything like that. And just to open it up too.
No, I saw the
Thank you.
signals that you're talking about in Grab and Smith, but it made it
Mhm.
so cumbersome to understand what they were saying or where they were going
No,
because it became
it's
molecular.
actually easy because you see what was actually, it was actually cumbersome, but it now made it easier for me to understand what was written in Grab and Smith, because written in Essentials, they summarized it. So the Grab and Smith opened it up so that if you are having difficulty understanding what is in Essential, this further essay in Grab and Smith will make it easy. You'll now be able to relate. But as you said, since it's essay, they may not even need all these details from us, unless if maybe somebody wants to ask us MCQs. Do you get? Mm. Thank you.
Okay, please, any more addition or correction? So we can move to classification of immunosuppressive agent. Okay, so Let me try and take this one. I got an acronym for the classes. The acronym sorry, mnemonic I got for to remember it is basic M, as in BASICM. The B stands for biologics. This is where you have basiliximab, rituximab, infliximab. There's another one, but these are the main ones I can remember. Then for the A is the antiproliferative agent. This is where there's mycophenolate, mofetil, and azathioprine. Then the S is the steroids, prednisolone, methylprednisolone. Um, the I is the induction agents. That's the anti-thymocyte globulin, alem. There's one alem zumib something or zumab something there. Then there's the calcineurin inhibitors. That's where there's cyclosporin A and tacrolimus. The M now stands for what's that again? I think mTOR inhibitors. That's rapamycin and everolimus. Now, when I read it, they still went further and gave the mode of actions for each of them. Some of the classes, the particular components in those classes have different modes of action. I don't know, it was difficult for me to remember all of them. And then they still went further and gave complications, common side effects that could occur with them. So I just tried to remember like the basic mode of action for a particular group. Like was already pointed out, the calcineurin inhibitors inhibits interleukin 2 gene transcription. The mTOR inhibitors inhibit signal transduction. I think there's another one that inhibits interleukin 2 receptor antagonism. I think that's basiliximab under the biologics. But the other biologics also have different mechanism of actions. I think infliximab inhibits tumor necrosis factor alpha inhibition. The induction agents inhibit antibody-dependent cell-mediated cytotoxicity. Then antiproliferative, they block DNA synthesis and replication. So there are still some others, but these are the ones I could remember. Then there are two particular adverse effects I saw for two classes. Cytokine release syndrome. I was supposed to check it, but I didn't check what it means. But cytokine release syndrome is found with both induction agents, the biologics. So I don't know if it could come out in MCQ. That type of thing is important to know. Then the mTOR inhibitors inhibit wound healing, so it reduces their application. As especially when you've just finished doing surgery, you might have to delay before using them. I think this is what I have for the classification. Thank you. So comments, addition,
Okay. So
corrections.
thank you, Chief Tommy. Well, I want to see it from a different perspective for clarity and for better understanding. Um, some people will say they would like to categorize the drugs into the fact that if you are going to give a patient, if you are going to do transplant for a patient, you want to initiate by suppressing rejection in the patient. Then you want to maintain that suppression in order for the transplanted agent to stay. Then, if while you are maintaining, you are not going to have, say, you're not going, you start having features of rejection. How do you rescue the patient in order to maintain the transplanted agent? So, some of the questions in MCQ will be dancing around what are the induction agents. Then they'll ask you what are the drugs for maintenance and what are the rescue modalities. Because in the rescue modalities, you will now find some people be dividing it into groups as like first line medications. What do you do? What drugs belong to the second line medication and what drugs belong to the third line medication, as in third line agents. Sorry. Now, some people may classify it like broadly into there are specific pharmacological agents that can use for as in for suppressing, and because all this that we're talking about is immunosuppression for suppressing the immune system from preventing rejection. They could be specific or they could be non-specific. So I think if I keep this like this in my head, it will, because I agree most of the drugs you are mentioning, they cut across groups. But now, if you should discuss it in that line, when you get to MCQs, when they start asking you for induction agent, you get confused because the induction agent, like now, for example, cut across three groups of drugs. You have the calcineurin, no, sorry, for induction, no, for maintenance, sorry, not induction. For maintenance, for example, you have three groups of drugs that are used for maintenance. You have the calcineurin inhibitors, you have the antimetabolites, and you have steroids. So if you have this in mind, you know that okay, when I'm maintaining these patients that has had transplant, these are the group of drugs because that's how some of the MCQs actually come out. So that give you list of drugs and tell you these three drugs are supposed to be for maintenance. But if you learn it the way you have mentioned it now, we'll have difficulties actually itemizing what goes for what and how we should follow. I don't know. It's just my own view. Others can also share their own views. Thank you.
Thank you for that, Dr. Osaze and Dr. Allison. I think that both of you are correct. What I think is that it's important to know the classes of the drugs. Then it's also important to know the regimen. You get, if you know the classes of drug, then the regimen, it will be easy to remember rather than cramming the regimen alone without knowing the classes of drug and their mechanism of action. That's, I think it makes it easier to remember and understand. If we know now that for maintenance therapy, you're using the calcineurin, antimetabolite, and steroid, and we know what each of them is doing, we will not forget easily. And so I think both of them are important. So we'll know the classes of drug and then the different regimen, as you've mentioned, we said in the induction, maintenance, and rescue. Were they, did you, it's like you mentioned four, right? Was it just
No,
three you mentioned?
I mentioned three. I said there was induction, there's
Induction,
maintenance, then there's rescue. But under
fine.
rescue, you now have what should
Okay,
you
first
do as
line and
first line,
second line.
second line,
Yes,
or third
yes,
line
yes,
before you say okay, there is no salvage of the
yes.
transplanted agent.
Mhm.
Now, but
Okay.
my question to Chief Allison is there really a class called induction for the medications? I agree that there are calcineurin, there are antimetabolites, there are steroids. Some actually even go ahead and say other groups. But is there a group called an induction? Because that falls under the use of the medication now rather than the class of the drug itself. Just asking for clarity. Thank you.
Oh, okay. Chief, thank you for that. Yes, in Grab and Smith, they actually gave a class on anti-thymocyte globulin. Anti-thymocyte globulin. I think that's one of them. Then there's one. I have difficulty pronouncing it. Whether is it Amel Alemtuzumab or something like that. Those two were in the induction agents, as in were the examples given the names of the induction agents. Now, this stuff you said about the regimen, I also came across it. What you're talking about now is the triple regimen, where there's the induction, maintenance, and well, where I read it, they talked about rejection, but rescue is still the same thing. But I couldn't find where they classified them into induction agents are these, maintenance agents are these, then the rescue agents are these.
It's an
Where I read
essential.
to the
It's an
okay,
essential.
okay, I didn't read essential. Then they
Essential.
also added to that to supplement this regimen, as in this triple regimen. Some people also that there are times they usually add an antibiotic, antifungal, and antiviral because the patients are now immunocompromised. But I don't know whether, as in, is it important to add that? Thank you. I'm done.
I think this subheading should have just been immunosuppression in transplant patients or something, instead of saying classification of immunosuppressive drugs. I don't know if
Okay.
you get. So that we don't just discuss it as classification. Maybe we just discuss a little about immunosuppression, then the drugs used. That's
Okay.
my opinion. Mm.
No,
Okay.
I tend to lean towards what he has said because it's not just the medications that falls under the category for immunosuppression. There are instances where even irradiation is done and is part of immunosuppression. So I tend to lean towards what he has said. Yes, I agree. So outside us discussing medications, we should also say other things that are needed for immunosuppression. Thank you, Dr. Chief Anthony.
Okay. The next part is okay. I think it was accepted now. Organ donation criteria.
And go ahead now, because we're waiting for you for in that part. Actually, I've been waiting for you to come and hear what you want to tell us. Because, for example, when you now come to practical, no, I'm being honest. When you come to practical application, for example, in plastic surgery, you understand. I want to hear now what your criteria is for transplant. Because we're not dealing with transplant in general, we're actually dealing with transplant in plastic surgery. So, what do you want to tell us? And tell us so we can hear. Preparing for exams, let's see if we will write that part.
Okay. On under here, Shad, I think when I was trying to create the outline, I tried to merge both what I read from plastic surgery, as in transplants in plastic surgery, and then general principles for transplantation. So I just felt when there's going to be any donation, or as in donation of organs or tissues or vascularized composites, allo transplants, there should be where I assume that it will still follow the same principle, the about the age, the it being altruistic, what's those other things, I think those other general principles for every other transplant. There's nothing specific. I didn't see it in a plastic surgery
Uh,
book.
uh, Chief
So the
Harrison,
idea.
you know what I'm asking, what I'm asking. You see, when we get to the practical applications of plastic of transplantation in plastic surgery, it will now appear as if that part is completely blurred out. For example,
Oh, okay.
if you take application in terms of skin graft or flaps, do you really need a criteria? If you talk about nasal reconstruction or auricular reconstruction, do you need a criteria? I don't know. That's where, because you don't want to start writing things that even the examiner is now wondering what this person is writing. So I want to hear
Okay.
you if there is something salient that you want to tell us that will make this part interesting. Because most of the books I went through, even in Converse, I don't think they really I tried to talk about a criteria for what you want to do because it doesn't fall under the ambit of us just transplants in plastic surgery is a bit unique because most of the things that you are going to be doing are fall under the ambit of autograft or allograft. But even those allograft materials are probably even irradiated before they are used. So you may not even really have what you want what you want to say. But however, you added it. I was just thinking maybe there was something interesting you wanted to tell us about the criteria. Because if you say age, for example, now a 6-year-old child is a 6-year-old child. If you want to do skin graft and you want to raise a flap for that child, at the age really, how would that affect what you really want to do if that is the option that you want to use in closing the defect? I don't know. It's just my
Please,
opinion. That's why I said I wanted to hear
Dr.
you.
Allison, sorry, please let me just, Dr. Allison, did you mean, do you mean the donor, criteria or
Yes.
indication for this
Is,
transplant?
no, it's the donor criteria. Those
Okay.
normal. Okay,
There are
like you
some
said, the
ethical,
age.
no,
But
do you know what? Okay, anyway, if there's another thing though, there are some ethical issues that you see, especially when you're talking about those vascularized composite grafts. Sometimes most of these patients are cadavers now, apart from skin grafts. You get. So probably if, maybe the only outline we can put is to ensure that consent had probably been taken in these cases where you have people stealing organs and selling organs. So if you want to say that, remember that for the vascularized composites, that allo transplantation, most of the time is from dead patients that they take it
No,
from. Maybe all those ones.
uh, yeah. I, I,
Yes,
Chief Anu, Chief Anu,
yes,
sorry, just a point of
yes.
correction. You know,
Mm.
this view that you hold is one view I used to hold before until Chief Sabo corrected me. The fact that they say that there are cadaveric um, materials doesn't mean that they are necessarily dead, though.
Sorry, I mean to say those ones that the person would die now and maybe
Because
on the organ
eh,
transplant, it may be on
no,
the ventilator and all those.
the way you mentioned it, like they are cadavers, they are not. That's those vascularized composite allografts. The patients are not dead yet when they took them. Oh. So don't really confuse because if the patient was completely dead, they won't have obtained composite allograft from them
No,
because it
it will
won't be
be,
viable.
but they are not from live patients. And do you mean brainstem dead? Like who are the
Yeah,
people they
yeah,
take from?
they are brainstem dead. They are not. I mean,
Brainstem
I don't
dead,
know how
yes.
they're not dead. The
Okay.
head, the way you are painting it.
Okay, no, and thank you. I'm using the wrong word. But
Mm.
obviously, probably if you want to, all those things, those criteria for if you wish to put it, as Dr. Saze has advised, it's not compulsory. But if you wish to remember those things about harvesting organs, that you have to ensure that one of the doctors is not part of the transplant team. Okay, yes, when you want to confirm brainstem dead, because those transplant doctors are interested in harvesting organs, so it may bias their decision making. They may have bias when they want to confirm somebody brainstem dead. Yes, so yes. So if you want to do that, that's for those categories for the vascularized composite. But of course, the topic is quite broad. It's both for the this transplantation, both is allogenic actually. So we can take from living donors and then those that are brainstem dead. So that's just my, if you want to add that. mm,
No, no,
that's
I'm
what.
not against. No, see, when we
No, it's
do
Dr.
FTD,
Allison. No, it's Dr.
yeah,
Allison. I'm just trying
yeah,
to suggest
okay, because
yes.
I'm not against that part. I just wanted to hear something interesting so that we'll write at least small part of it and add to our essay. It doesn't
I
take
think we
anything
can,
away
if we
from
want
the
to do
essay.
that, this may be that to ensure that,
So
of
he,
course, the person would have given consent now. The person
yeah,
would have
Chief
already
Allison, that's why
consented
Chief
that the
Allison, let Chief
organs should be
Allison dwell
donated.
on it and let's see.
Sir?
I say allow Chief Allison to dwell on it. Let him give us the donor criteria as just a refresher, then we'll move on.
Okay, that's fine.
Okay, so the ideal donor criteria, the age is supposed to be between 18 and 65. But like I said, this one is ideal. It's not everything here that has to be followed strictly, but at least you're striving to get some of them. Then the patient should be infection free, especially the viruses, cytomegalovirus, HIV, hepatitis B. Then it should be tumor free. Should also be free of comorbidities, and there should be adequate residual organ function post donation. So these ones they are ideal criteria, but like was already cited, some of the patients you may not be able to get all these things in one particular patient. But I think things like the tumor, the infection, I was assuming that they follow them strictly.
Okay, now that you're mentioning, I tend to agree that that part of it is also important in our essay. I think there was a time we had one child that had extensive burns, and my boss was considering the fact that she needed to harvest skin from the mother in order to temporarily cover the child to see if we could reduce the metabolic response in the child before we could do other things. Yes, I agree because if the mother, for example, carried infections such as hepatitis, carried other infections, it won't be good because we'll now be transferring such infections from the mother to the child unknowingly. So it means that yes, donor criteria, you need to actually look at the donor even before you do certain things. So like you said, infection, yes, tumor, yes, and the age of the patient should also be appropriate. You won't want to do things that are not making sense. 18 to 65 is usually the age for which you want to harvest from a donor. So yes, you have made the point, and it's clear. Like I said I just wanted to hear you out. Let's see if we can logically think about it and write it in our essay. Thank you so much, Dr. Allison.
Okay, thank you, Chief. Sorry, in addition, now there was something that came up some years ago, I think like 4 years or so, in South Africa, a child that was dying and needed the liver transplant. The mother wanted to donate, but she was HIV positive. They finally agreed and took. So I don't know that's the type of thing that somebody can bring up if you mention HIV. So it's just good to have it out there. It has been done before in South Africa. Thank you. Okay. Are there other comments or corrections? Can we go to organ retrieval and preservation? Okay, so let's go to organ retrieval and preservation. Under this organ retrieval, what I was actually trying to talk about, what I saw was maybe I didn't put the heading well, but when you talk about something like warm ischemia time, cold ischemia time, and then the solutions that are used to preserve these organs or these tissues. So like, but the thing now is that the warm ischemia time and the cold ischemia time is like they're different for different tissues. I saw for the fingers, I think it's 24 hours for cold, 12 hours for warm. I still saw somewhere where they said 30 hours. I think that was Medscape, but I don't know what the consensus time is. But this is for digits. When now it involves the forearm, the arm. Of course, the time will be shorter, but I cannot tell exactly what it is because when I was reading, I didn't exactly see it. They just said it will be of a shorter time. I don't know what the time is for the face or for the bone and other tissues. For the preservation fluids. Okay, first there's supposed to be a definition. For the cold ischemia time is the time from perfusion of an organ by cold solution until transplantation into the recipient, while the warm ischemia time is supposed to be the time from, let's say, from death till when you do the infusion into a cold, the maximum interval between the donor's death to when there's perfusion with with the proper solution, the preservation solution. So that was what I was talking about for the organ retrieval. For the preservation,
Allison, Allison.
yeah,
So,
I can hear you.
okay, just the point of correction. Is it that I think it was actually when the tissue is devoid, as in is taking off its own blood supply, but the tissues are still preserved till when the tissue is actually inside the solution. It's not, don't use the word death because it will look like the tissues are now necrosed. I don't know. Maybe you should check up that definition again for warm ischemic time.
Okay, I'll check. I'll check. Thank you. Thank you for that. Okay, then the solutions. I didn't really read in depth for all of them, but I just saw that they use University of Wisconsin solution. I don't know which particular tissues are put into which particular solution, especially this one for plastic surgery. I didn't see any in particular, but I know there is University of Wisconsin solution. There is the Institute George Lopez solution. There's histidine, tryptophan, ketoglutarate solution. So I don't know whether it's also important to add here that stuff when we are transferring like a severed limb. Uh Whether it's important like wrapping it in saline soap gauze and putting inside a um wrapping wrapping that inside a bag before putting into a cooler that has slushy ice inside to preserve it. I don't know whether it's important to also mention it here. Then the fact too that skin and bone can also be preserved inside the fridge at 4 degrees Celsius. These were just some of the small things I wanted to add here. Thank you. So, comments, corrections, floor is open.
Thank you, Dr. Allison. Just wanted to add that that's preservation in the ice slush that we'll do. I'm not sure if it will be applicable here. Not so certain if it will. Not so certain. I don't know what the other people think about it. Not so
Okay.
certain. But it's come to think of it again. I know some of these some of these donors. Some people have already put in an indicated interest in donating, but they may not die in the hospital. So maybe those ones that die elsewhere, since they've already signed, and if they're able to reach before the one ischemia time is expired, probably, because most of the time you need to do a surgery and harvest it before you transfer it to the other part. Is it not so? So I'm just thinking out loud. What do we think? Must all the patients that
Must
fill this
all the patients
criteria
that fill this criteria
bring
be
brainstem them?
brainstem them?
All donors, especially
All
for the
donors, especially for the video.
Okay. So the
Okay.
floor is still
So the
open for
floor is
comments
still
and
open for
questions.
Sadiq.
comments and
Dr.
questions.
Sadiq, is it
Okay, yeah, I wanted to say it's like it's more applicable for replantation than transplantation.
yes, the
Okay.
is it the
Is
preservation
it
in
the
the
preservation in
sludge?
this flush?
Yes.
Okay.
Do we move to applications in plastic surgery?
Please, there's a part we've forgotten, types of rejection.
I was putting that under complications because like
Okay,
the complications are divided into anesthetic, surgical, then immunosuppressive complications, rejection complications.
okay, thank you.
Mhm. So application in plastic surgery. Is anyone taking it? The application in plastic surgery.
Hello?
Is it?
Okay.
Yeah.
Yeah, sorry. I've actually put down some things in preparation for this presentation, but I've had some issues with call actually, so I don't have these things ready with me. But I think I will just want to contribute a little on that. So, with
Okay.
regard to the application in plastic surgery, so like as it has been mentioned in the history, actually, the organ, the transplantation actually is in the pioneering days was mostly having to do with solid organ transplants. And most of the studies that have been done on transplants were done on those solid organs. However, with regard to application in plastic surgery, most of the transplantation has to do with the transplantation of integumentary structures, which can be done either singly or as composite tissues. Singly, in the sense that allotransplantation of skin, which is one of the commonest things that we do, and then flaps, like have already been mentioned, muscle flaps, musculocutaneous flaps, and so on. But I think the one of interest here is the vascularized tissue allotransplantations, which was formerly known as, I think, the composite tissue allotransplantation, something like that, CTA. But now I think the most preferred terminology now is the vascularized composite allotransplantation. So the tissues of interest that are mostly transplanted in plastic surgery will include the different types of facial transplants. Like I've been mentioned already, the partial facial transplant, which usually involves the nose mouth triangle. That's the common partial one that is done, and then the total or the total facial transplant, which usually is the transplantation of the face, usually starting from the forehead, the anterior hairline, down to the junction of the chin, and then the anterior neck. And then the extended one, as has been described earlier, where the transplantation will include the scalp, beginning from the coronal section of the scalp down to the upper borders of the clavicle. So in that transplantation of the face, actually, just like has been mentioned, is composite. So it will include things like the skin, the muzzle, the subaponeurotic muscular, sorry, the SMAS. Somebody can help me with that, please. I think submuscular aponeurotic system, and then sometimes even underlying bones of the face can also be included in the transplantation. The other one I think is the transplantation of the upper limb, usually the hand transplantation. So the issues to discuss here, I think the technique. So the technique is just the same thing as The techniques that are involved actually are two things basically. Number one is the technique of organ harvest that will be employed, and then number two, the technique of microvascular anastomosis. So the organs are harvested just as have been discussed based on the criteria that were earlier discussed, the criteria in terms of the donor. So once the organ is harvested, is now transplanted by anastomosis to the recipient vessels in the individual that is receiving the transplantation. So I don't know, maybe other speakers will add more to it. Thank you.
Okay, thank you for that. So there are still other structures that could be transplanted. I think he dwelt more on the face. So I don't know if any other person still has more to talk about for other structures that are transplanted in plastic surgery.
Okay, sorry. Yeah, I said the face, the different types of the face, and then the hand or the upper limb generally, the forearm and hand can be transplanted. Then these are the composites. But apart from the composite, also tissues, I mean singly, not as composite tissues, like for instance, cartilage transplant. So cartilage transplant, the donors usually are the conchal cartilage, the nasal septum, and then the rib. That's the donor this thing. So what is peculiar to it is that the chondrocytes, in terms of cartilage, the chondrocytes are protected by the matrix. So this rejection actually is less in cartilage transplants. Then bone, also bone transplant can be done. Multiple donor sites, of course, for bone. But one thing with the bone transplant is that once it is transplanted, the osteocytes, actually the processes of rejection will be set in motion, and then the osteocytes will get necrosed. But the bone will remain as a scaffold. And then through a process, I've forgotten the name of process, where the osteocytes from the recipient will now be integrated into the scaffold that was left behind by the previous bone. So the
Creeping
peculiarity of
substitution.
creeping substitute, thank you very much. So the peculiarity of that one is that the implant that is used for the fixation will have to be left in place longer than if it were a normal fixation that does not involve transplantation, allotransplantation from another individual. Then for nerve tissue, it can also be transplanted. The peculiarity with nerves is that once it is transplanted, actually, just like it occurs in the individual, even not in transplant, when there's transection of the nerve, there will be Wallerian degeneration distal to that side. So even in the allograft that is transplanted, the part that is transplanted, the neural tissue itself will degenerate, and then the myelin sheet around it is actually what will remain. So it will serve as a tubular scaffold for ingrowth of the nerve tissue from the donor site, the proximal part in the donor site, through that and then to the target organ. Then which other tissue again? Then of course the skin is the one we commonly do, so I don't think I'm going to dwell on that. So I think that is that. Then other speakers can contribute. Thank you.
Okay. Thank you for that. Thank you for that. In addition, the bone allograft that you're talking about, there are two types. There's the non-vascularized and the vascularized. So most of what you said is for the non-vascularized, where the bone may have already been irradiated. Just um, very few how do I call it? Will I say antigenic cells are alive in it to cause a response. But as you said, to the recipient's body will actually create use that graft and create like a scaffold and start laying bone on it, and that whole bone will get reabsorbed over time. Some literature even say that following that it's a bit confusing whether it should actually be thought of as a graft or not, but that one is another issue. There is still vascularized bone grafts, but because of the amount of immunosuppressive agents that may be used to be able to reduce the risk of rejection, it's I don't think it really has application in surgery. I stand to be corrected. I think I saw something like that. So most of what is done is this non-vascularized bone graft that you described.
Sorry,
Thank
the
you.
vascularized. Sorry, thank you. The vascularized is also done. Well, the problem with that vascularized is that it has been found that the supply, the blood supply for bone is dual. One of it comes from the vasculature in the periosteum, and then there's the endosteal vasculature. So it has been found actually that what mediates the high antigenicity is the endosteal component. So what is done, I've seen in one of the literatures, I can't remember which one, is that the endosteal component is the one that they get rid of it. It is removed, like curated like that. And then it leaves only the periosteal one. So it decreases the antigenicity, and then it lessens the need actually for um, immunosuppression because of the decreased antigenicity in that setting. Thank you.
Okay, I came across that, but I think it's more experimental. I don't know, from what me I saw, that you can actually take the recipient's own bone marrow and introduce into the bone to try and reduce the, more or less to create some type of chimerism to reduce the risk of rejection. But clinical application, I don't know whether it's being applied because of the prolonged immunosuppression that will be required. Okay, please, other comments, corrections, additions. This is the meat of the matter, the application of transplantation in plastic surgery. Okay, I think there's also room for. I think I saw something like even the anterior abdominal wall has been replaced before.
And the transplant, yes, it was there. Yes.
Yeah, Chief, I think theoretically everything can be transplanted. It depends on whether it has been done or not. So, but people are doing it now. So, almost every part of the body, as long as it falls within the this thing, all those integumentary structures, whether the anterior abdominal wall, the back, the limb, or whichever one. The only thing is to apply the principle in terms of the surgical principles to find a recipient blood vessel to do the microvascular anastomosis and then the immunosuppression that is involved. So I think it depends on whether one has found or read about it or not. If not, practically all of these things can be transplanted. Thank you.
Okay. Mm. Okay, thank you. So the next section is the complications. Is anyone going to take the complications?
Sorry to take us back. For that applications under skin, I wanted to mention, we'll still mention what we use it for, indicated in extensive bonds when you're using the allograft. I think the applications, as we mentioned, the maybe for bone, we'll now say give instances where the bone allograft would help. So we'll say the indication you get. So for the upper limb, we'll say it. Those penile reimplantation that has been done, transplantation, penile
Yeah.
transplantation, either those that had, they've had failed repairs for all mutilating injuries with loss, even the face. So we'll mention we'll mention face transplant. We'll now mention when it is indicated. For skin, we'll mention it just to add that. Cartilage, we'll mention where we'll use it, probably for ear reconstruction. I don't know if they've used it for that, but I think those are the practical. We'll now mention where and where we're using it for in each of them. Thank you.
Okay, sorry, as you said this now, I also remember the is skin xenograft. That is to use either porcine skin or fish skin. That will almost be like a temporary cover.
Yes.
Okay, and Dr. Honor, the best way to actually look at the application in plastic surgery is not to always consider that they are allografts. You understand? Like you were mentioning, in order for us to write extensively, you always remember that there are autograph then allograft because transplantation within self is still transplantation. You understand? So
Yeah.
that you are broad in your thinking. Like in
In
skin,
the
you will
thinking,
not
yes.
just say allograft alone. There's
Mm.
autograft, there's allograft, there is xenograft. So it gives you a broader perspective in your discussion. And even in that extensive bonds that you are talking about, we will not forget the Alexander technique, where where you have limited donor sites, you harvest skin and widely you mesh them, but the spacing is quite large. But because you cannot reduce the metabolic response in the child, you now harvest and get another allograft that is finely meshed and cover again, just to reduce, because the initial one you got was the spacing was the interstices are too wide, so it's the losses are still more for the child. So you now get another allograft and combine. That's the in the colloquial parlance where they will say the sandwich technique, where you are combining both an allograft and an autograft on the same sitting for extensive bonds. So you just keep mentioning it that way, as in skin, it has been used in skin. You remember autograft, allograft, and xenograft. And when we come to nasal reconstruction, you also remember the various sites, just like Chief um, Quarry said, as in the various sites where you can actually harvest. Then we leave them, you go to nerve, because he actually gave a broad beginning when he said you can either fall in under the vascularized composite or it falls under single. So that way we'll be able to discuss extensively. I think we have done well because we have mentioned practically everything. We have mentioned the abdomen, we have mentioned P9. What is left, please? I want to do full body. Well, I've done everything.
Okay, so sorry, Chief. Since you have mentioned that thing on skin, what of the other one? Is it Cuomo or Suomo now? The
Okay,
pronunciation.
the Como technique.
Aha.
Yeah,
So that one too, I think is important to mention.
yes,
You know,
mention.
the yeah. So
Please
the
go
area of
ahead.
antigenicity in the skin, you know, the what do you call it now? The antigen presenting cell in the skin is the skin equivalent of the dendritic cell. That's the Langerhans cell,
Yes, yeah.
and they are predominantly in the epidermal layer of the skin. The
So some
dermal
people
layer
will say you
actually
want
don't.
to take out that layer.
Yeah, so it's dermabraided. This thing is laid as an allograft, the skin, and then it now is dermabraided before that day, between that, day 4 to 7. That's when the allogenic rejection starts. Day 1 to 3 is just like the ordinary skin, the normal autograft. So day 4 to 7, that's the critical time. So it's in that critical time that it will be dermabraided to remove that layer that is highly immunogenic or antigenic. And then you can now do either cultured keratinocyte. So that means that the dermal layer there is left behind to give support for the cultured keratinocyte. Then somebody mentioned something on xenograft. I think we also forgot to mention the concept of there's this concept in xenograft of is it a discordant and concordant this thing. There was a time I
Okay,
had
I
to leave the
remember.
presentation. I don't know if somebody has mentioned that.
Okay, no, you just mentioned it now. Remember that the discordant and concordant
Yeah, so
way of
it's good to yeah, it's good to remember. So there are some species that they have this discordance. Like one of the common things that are transplanted as xenografts is pig, porcine skin, and so on. So porcine skin or pigs generally, they have this natural antigenic incompatibility with humans. So because of that, it's classified as discordant.
discordant.
But there are some species actually that natural pre-existing immune response is actually not there. So example are the primates. So from
Primate.
primates, you can do the xenograft without primates generally, chimpanzees and gorillas and so on. So, but actually in practice, I've not seen where tissues from those primates for the pig. Yes, I know, but yeah. So thank you.
No, I agree. I agree. It's just to be able to discuss extensively when it comes to the application, because I think in this whole essay, that's where the mark sit down. Because if you look at it, when they coin questions, you want to find out where you have the optimum marks. In order for you to have the optimum point, you need to go and discuss in that area. If not, you have less marks.
Yeah,
Okay.
so these bone allografts for probably following tissue tumor excision. Those so we'll do that tumor to bone tumor excision. We'll take it and then replace. Oh, thank you.
Okay, so the next section is the complications I think we should skip the anesthetic and the surgical since it's general for every other condition in surgery. So the most important here are the immunosuppressive rejection. For the rejection, there is the hyperacute rejection. Me, I don't have much information on this and all the cells, but the time it's almost immediate as you're putting in the graft, you're seeing the reaction that the body is having to the tissue that is being transplanted. Then there is the acute rejection
The
that is
hyperacute
from
is within minutes.
okay within minutes. Okay,
Yes,
then
within minutes.
for
And
the
that is,
acute,
but you need to complete it now. Finish the hyperacute. What is responsible? It's because in such individuals they already have preformed antibodies in them. You understand? If, for example, if the patient is pregnant and has been exposed, or if he has had previous blood transfusion, or he has had a transplant of same or had that transplant before and be exposed to that antigen, so his body has already has preformed antibodies. So it's like what they call the second sex phenomenon. He has been exposed. So the rate at which the body now activates T cells to reject that particular tissue is a minute. So as you are laying it, it is dying. So such transplants are removed immediately in order not to stimulate a an inflammatory response. So the management there is easy. You just take out the transplanted tissue. It's not as if you're going to give any medication. So some people will not ask in MCQs that what type of cell mediation is it? I think it's a type 2, um, if I'm correct. Yes, I think it's a type 2 reaction that you get because of MCQ. They'll start asking you the hyperacute, what type of reaction is taking place? Is a type 2 reaction and that takes place in it. Yeah, move on.
Yeah, sorry. So for the
okay,
hyperacute, actually, two things. So the what do you call it now? The complement and then preformed antibodies. These are the main things actually
That's the main things
that
you
are
need to
called into
know.
play.
Yeah.
Complement and preformed antibodies. So that's why it is immediate, minutes to hours, but mostly minutes, within minutes.
Minutes.
Thank you.
Yes.
Mm.
okay. So thank you for that. The next one is the acute rejection. This all happens between I think days to weeks. It usually causes when the immunosuppression is reduced or if there's an infection. The primary mediator is the T cells that infiltrate the graft and lead to inflammation. But some of them are also mediated by antibodies. I think donor-specific IgG antibodies.
You know, this
Um,
is where
the-
that's where
Sorry.
some books are textbook. I think this part you are discussing now is where you will now start having variations in most of the textbooks because
Okay.
some people agree that the acutes that you are talking about would not take place until after 1 week. You understand? And it's part of that reason why some books started bringing in other terminologies because even me, I started questioning if one takes place in minutes, the other one took place in 1 week. What now happens in between? That's where some books like Essential started talking about accelerated. So it's not all books that you see accelerated. Some books just say it is acute, it's hyperacute, acute, and chronic. But some books now bring in accelerated because most books do agree that the acute will not happen until after weeks of exposure. So if that is the concept, then what happens in between? Then other articles started talking about accelerated.
Okay. Well, as in, I read this from Grab and Smith, and they also still mentioned that it may happen much later, between, as in, the same months or even years. That one now was a bit confusing for me because then how do I now differentiate it from the chronic? But noted, Chief. Noted.
Okay, so sorry. The distinction into hyperacute, accelerated, acute, and chronic. I think it's also important for us to take note that that accelerated is actually a subset of the acute. So the once it is not within minutes or hours, once it has gone into days, because many of the books actually that don't have that accelerated, they
Talk
reckon that
about
the
this.
acute, they reckon
Yes.
that the acute is actually days to weeks. So, but
Yes.
if you want to now differentiate them, then when it happens less than 7 days, that's less than a week, then you can now sub-classify it as accelerated.
Okay.
And then when it has reached a week or longer, it now becomes acute.
Okay.
But in case you see in MCQ, if accelerated is not part of it, if they just mention as once you see days, it has gone into days, is already acute.
Okay.
But if they decide to separate it, then days is accelerated, weeks will now become acute.
Okay.
Now that distinction between acute and chronic also is important for us to know that acute rejection may actually not necessarily happen in that time of weeks. In fact, it may even take a year or longer. Now, what happens is that acute rejection, you differentiate it from chronic, is actually a pathological diagnosis. Because
True.
once you take the biopsy and then there are no features of those chronic inflammatory cells, and then the immune complex deposition, which are the hallmarks of the chronic rejection, once it is not there, is still classified as acute, and the treatment will be the same treatment that is done for acute. It's very important to differentiate because that will tell you how to manage that complication. But once you see those chronic cells, and then those what do you call them, the chronic inflammatory cells and the immune complex deposits, which are pathognomonic for the chronic, then that means the management of that particular rejection will now be the management for chronic rejection. Thank you.
Okay, thank
Thank
you,
you.
Chief.
Thank you so much, Dr. Karen. It's quite very clear the way you have said it.
Hmm.
Thank you.
Yeah, you're welcome.
Okay, so the acute is usually treated with steroid therapy, plasmapheresis, IVIG, high dose IVIG, then antibody treatment. For the chronic rejection, this usually from years. In fact, I think the definition is from 1 year. That's where you can decide that it's chronic rejection. One of the leading causes of one of the leading complications that affects long-term transplants. It's usually perpetuated by both the humoral and the cellular responses. I can't remember what causes the first phase, but the second phase is dominated by the macrophages that will release interleukin-1, tumor necrosis factor alpha, that will lead to fibrosis and loss of function of the affected parts. I think these are the things I can remember for this chronic one. This is what I can remember for the chronic.
Sorry, Chief, the immunology of the accelerated and the acute, have you discussed them? Because we mentioned that the complement and preformed antibody for hyperacute, then for the accelerated is reactivation T cell. That means that they are pre-sensitized T lymphocytes. So those pre-sensitized T lymphocytes, even if they have been pre-sensitized, because of the way the T lymphocytes function, because they have to release those cytokines that were mentioned earlier, that interleukin 2, tumor necrosis factor alpha, interferon gamma, tumor necrosis factor alpha and beta. So it will take those ones to now stimulate macrophages and natural killer cells. So even if the patient is pre-sensitized, for that one to take place, it will take days. It cannot happen like in the hyperacute case. So that's the one that's responsible for the accelerated. But for the acute one, then activation T cell, which means the T cells have not been previously sensitized. So it is now that they will now become sensitized, and then the process will now start going on. That's why it will take up to that 7 days or longer. Thank you.
So, in chief query, it means that the difference between the accelerated and the acute is that in the accelerated you have sensitized T cells, but in the
Yes,
acute you just have T cells, but they are yet to be
yes,
sensitized because
yes.
it's still T
Not
cells
previously
that is
sensitized.
present for the cell. Okay, because
Yes,
because
yes.
you know why we're stressing on this, because those silly MCQ questions, they will now actually write sensitized in one and not write sensitized in the other, and make it quite confusing when you are looking at it. Because I've been seeing
Okay.
MCQs, a lot of them on this issue, and if you are not really clear, you will not know what to choose because they are not looking similar. Thank you, Chief
Yeah,
Query, for the
so I
explanation.
think the memory aid here, is that to know that both of them, you understand, what happens actually is T cell mediated. So one doesn't have to actually commit it to memory by rote. Just remember that if it is both T cell, which one will now be faster? Is it the pre-sensitized or the one that has not been pre-sensitized? That's all. So
That's
Mm,
pre-sensitized, of course, you know it will be faster. So that's it. But both of them are T cell mediated. Thank you.
mm. I
Thank
think
you,
there's
Chief
some
Query.
form of for that acute. There's some form of humoral response too. There's some form of antibody, but it's just a few. That's why sometimes you may need to do that plasma pheresis. Mm. In the acute.
Yeah. Yes.
Yes.
Thank you very much. Yeah, it's still
The,
also
the
part of it. Yes.
yes. The problem, something I was trying to that was not linking up was I remember when we were talking about types of T cell activation, we talked about direct and indirect, and we're saying the direct was what occurs in the acute rejection, I mean, and the indirect is what happens in the chronic rejection. Just that when you come and start reading it, it's now not looking exactly the same, but it's still the T cells. But then I don't know. I was checking it and it wasn't looking. But in case they ask, we'll remember again when we're talking about that direct and indirect and what type of rejection it will cause. Thank you.
Sorry, Chief. The direct and the
Mhm.
indirect, I thought it has been discussed earlier. I think we have trashed out that one now.
We have.
It
Yeah,
doesn't actually,
you
it
know
doesn't
that
actually,
there was a link there. They were saying the direct was responsible for acute rejection. It was even one of the MCQ questions we answered, if you remember. That which one
but
is mm,
but that direct and indirect, is it really about whether it is acute or chronic? Because both of them actually will activate the T lymphocytes, and then
Yeah,
the process
yes,
will
yeah.
now
both of
continue
them
downstream.
will. Yes,
That's
both
I
of
think
them
correct.
will.
the important thing for us to remember about that one is the fact that the first one we mentioned, what was it now? The
Direct.
direct. The direct is, there are some books that will tell you that the direct is actually specific to what do you call it now, to allotransplant rejection. But that indirect is the pathway through which the body recognizes all foreign antigens, whether transplantation or foreign antigens from viruses, bacteria, and so on. That indirect pathway. So, but
Mm,
that direct pathway is specific to transplantation rejection.
okay.
Yes. Thank you.
Mm, thank you. Dr.
Chief
Allison,
Query.
continue. Chronic.
Thank you. Yes, I just remembered all the things I was trying to say. For the chronic rejection, one of the initial things that could also start it is acute rejection. So it leads to some scarring, and then um, from that scarring, it will still go forward because the chronic rejection usually takes sometimes even years to happen. Even though it may start from 1 year, it may take a very long time before it starts to manifest. There'll be gradual reduction in the function of the tissue that was transplanted. For this immunology part, I don't know, I will need help, but I know that the second phase is mediated by macrophage, and it secretes, or it causes the release of interleukin 1 tumor necrosis factor alpha that will put the graft in that chronic inflammatory state that will finally lead to the fibrosis and loss of function. So then I don't know if there's any extra thing that has to be said. I don't know if people will still make inputs on that. Then the last one is supposed to be the graft versus host disease, where the cells from the immune cells from the graft that is coming from the donor that are attacking the cells of the recipient. Now, this particular one, when I was reading the normal plastic surgery textbooks, I didn't really see much on it, so I cannot really remember the immunology about it. But I know that there's graft versus host disease. Yeah, so there are
Graft,
also some.
sorry, Chief, the graft versus host disease, I think is the same thing as the immunology, this thing we have just been describing now. It's just that you reverse it. that recognition that will be done by the recipient donor side. It is now the recipient donor tissue. It is now the donor T lymphocytes that will now recognize the, what do you call it now, the recipient antigen presenting cells as foreign instead of the other way around. And then the whole cascade of reactions will now take place as in the ones we have just described earlier.
Okay. Okay.
That happens usually when the host, that's the recipient, is not immunocompetent or is immunocompromised. So this thing is now more immunocompetent, the transplanted tissue. So it is the one that will now do the rejection instead of the host to reject the transplanted tissue. Thank you.
Okay. Thank you, Chief, for that. Then they also this one I read it from normal general principles for transplants. They gave some criteria for you to make the diagnosis for the graft versus host disease. That the okay, as you said, the recipient that is histo incompatible. Okay, no, you were talking about not being immunocompetent. They say recipient that is histo immunocompatible, recipient that is immunocompromised. Yes, that's the one you mentioned. And then an immune competent graft with functional immune cells. Those were the criteria. I think it's Billingham criteria to make the diagnosis of gross graft versus host disease. Then for the immunosuppression, the complication due to immunosuppression is basically due to the drugs. So most of the drugs have specific complications that are specific to them. Of course, since they are steroids, there's the risk of the patient coming down with metabolic abnormalities like diabetes mellitus, then even hypertension. There could also be difficulty in wound healing due to some of the drugs like the mTOR inhibitors, as I mentioned. There are a lot of complications. In fact, each class has different complications. So I want to stop here. Thank you.
Okay, you have mentioned most of the complications now, but I think one of the complications that they always pay attention to is the calcineurin inhibitors, especially tacrolimus, where they ask what are the complications. You know, tacrolimus has very what's that called now? What's
Nephrotoxicity.
the word? Yes, it's nephrotoxic, but outside being nephrotoxic, it has a very narrow window. So when using it, you have to closely monitor the patient. You understand?
Okay.
Then
Okay.
but you know why some people will say even though it has that demerit, it also has its own advantages, especially when it's given at low dose and is used for patients that has nerve transplant. It seems to have benefits for such patients as against
Yes, I saw that.
yes, as against the nephrotoxicity at high doses. So it's just to itemize the possible complications, just the way you have mentioned for the steroids, you itemize the possible complications that can emanate from it, then the various other classes of drugs that are used, the possible complications that could also emanate from them. No, nothing big. You know, when you get to this part of your write-up, you are actually coming to a conclusion.
There's also the risk of skin cancer, and I think SCC is the commonest skin cancer following the use of those immunosuppressive agents.
Okay, yes, yeah, I think I saw that because there's an MCQ that highlighted that. And I said, but they didn't put it as SSA, they put it as keratotic lesions as
Okay,
the,
okay.
and I said,
Okay,
what are
yes.
the commonest complications associated with immunosuppressive agents? Rather than put it as SSA, they now put keratotic lesions. You know, they just keep finding a way to twist the thing and make it difficult.
Yeah,
Okay.
I also saw I think it's transplant related lymphoproliferative disorder. as one of the communications. It's still the same cancer, but I don't know. They just give it a unique name or something. But it has to do with white blood cells that will be replicating abnormally.
Moderator,
Okay.
are with
Oh,
you?
sorry. We're we're almost done. The remaining parts now would have been ethics. I don't know whether we should jump that. We've already talked about
I
consent
think
before
we
now.
have talked about consent already now. I will try to talk about, should we dwell on that in plastic? I don't know. I don't.
Which one, consent?
No, 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 not consent. We've talked about consent initially now.
The
Because
okay, the
okay, like
ethical concerns.
The ethical
eh, eh,
part of,
because like when I was reading it now, one of the complications was actually a they gave psychological complications. One of the examples that was cited, they did a penile transplant in I think China or something. And after some weeks, the husband and wife came back and told them to remove it. That they, I don't know what it was doing to them, but they wanted it removed, even though there
yes,
was no
such, no,
reaction.
yes. I think those psychological issues had more to do with patients that had the vascularized composite allograft. Even for individuals, there are articles where you find that individuals that had hand transplants after a while were not happy with the fact that the hand was not theirs. Just the way the article you're talking about now, some patients were not comfortable with the penile transplant that they got. So there are psychosocial issues with the various forms of transplant, but it was common with the vascularized composite allograft than the other ones that were single.
Okay. Okay. Thank you for that, Chief. The next thing I want to talk about was local regional issues. So now in general, most people know the challenges we have with transplants in our different centers and zones. Then after that was supposed to be the recent trends. Most of the recent trends are geared towards trying to reduce the toxic amount, as in the toxicity of the drugs that are needed for immuno to reduce the risk of rejection. So they talked about a minimization protocol where they were injecting, was it either it's bone marrow or some of those like the patient's own cells into the transplanted tissue, so that they can give just a monotherapy of maybe just a calcineurin inhibitor instead of having to give three and have the side effects that comes with the three. But it's still experimental. They also talked about um, r- using tissue engineering to regenerate nerves, vessels, and bones, and also bioprinting for limbs and vascularized graft to improve the take and reduce the risk of rejection. Yeah, so that was what I saw for recent trends. So the last thing is conclusion. So I think we are done. Maybe if there's still time, whether we'll do the post test or do we skip it?
There's something about tolerance, transplant tolerance. I'm not sure where we'll put it, but that's the aim in the future, to achieve transplant tolerance such that the body will not recognize that the body will not recognize the graft, the whatever the transplant in it, you get. So, or you use low
Okay.
dose that will not affect that, as well as, yes, because of the side effect. The aim is just to reduce the side effect tolerance of all these immunosuppressive agents that are being used. Mm.
Okay, yes, I think I saw that. I don't know how I omitted it. They talked
I'm
about
not sure where we should put that tolerance. I'm not sure which part of the outline, but some books they discuss
no, I didn't put it.
its own.
It's in Grab and Smith. It's there too. They talked about like a type of donor-related hypo responsiveness, even though
Yeah,
the patient is still competent to launch a response if there are infections and other stuff. So,
exactly.
but I
Yeah.
saw it. I saw it. Thank you.
So it's also part of one of the future to achieve. Once they're able to achieve this, then it will become like a routine procedure. This transplantation, it was is one of the immunosuppression from all these drugs. Complicated side effects is one of the main barriers to making it routine.
Okay. Okay. Thank you for that, Chief. Okay, so over to you now. I don't know whether we are still going to do the post test because it's like 11:15. Okay, 11:20 already.
Everybody, is everybody. Like the people that are here, Dr. Sadiq, Dr. Adeze, Osaze, Uzoho, Audi, Alice. What do we think? Do we call it a night? 11:20. So we've already concluded.
The others are already
Yeah,
sleeping.
I think so.
I'll start
So
by
I
It
think
has
we
been
use the
4 o'clock.
the
I've
language of
slept
the Senate.
past 1 hour.